Assalamu alaikum. We are going to begin the cognition session of the PAP conference. Please wait for the Qiraat of Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد.
Jazakallah. In this session, I'll be your moderator. I'm Dr. Humaira Rafiq, and our chairman and panelist will be Professor Dr. Bushra Muiz, and she needs no introduction. She's the head of the Department of Hematology in Aga Khan University Hospital. Our first speaker is Dr. Lubna. Dr. Lubna Zafar, she is the consultant hematologist at Fauji Foundation, Rawalpindi. She is also the president of Hemophilia Patient Welfare Society, where she has been voluntarily working for the last 20 years. She will be sharing her experience and telling us the updates on the management of hemophilia. Please, Dr. Lubna Zafar.
Bismillahirrahmanirrahim. Assalamu alaikum, everybody. First of all, I would like to thank the PAP organizers for inviting me to deliver this talk, or rather update about management of hemophilia. And I'm really honored to be here amongst you. And I have been volunteering for hemophilia patients for the last about more than 20 years. Hemophilia is an inherited bleeding disorder in which there is deficiency of factor 8 mostly, and also factor 9, that is also called hemophilia B actually. And it is a disease which is very much here, but somehow kind of a neglected agenda. I hope कि सबको आ ही रही होगी आवाज. So hemophilia used to be a debilitating disease causing lot of crippling and morbidity, even mortality. But now the present day scenario in the West at least, it is actually compatible with perfectly normal lives. But unfortunately, we are much behind in management of hemophilia. So I would like to share what's happening in the government hospitals and how it is being managed by private organizations. So we actually have a hybrid system, and I'll briefly touch upon what the latest developments are. So we all know about the incidence, 1 in 10,000 and even less actually. It is an X-linked disorder, and so males are affected, and deficiency or absence of factor 8 is there, and family history is present in nearly 2/3 of the cases, but sometimes 1/3 patients, they don't give any history, so probably a new mutation is there. Sorry, अब उन्होंने वेट नहीं किया आपका? Okay. So these are the latest stats, and as you can see that as our population is concerned, we have an estimated number of 25,000 patients, and only about 5,000 they are registered in different chapters or organizations which are working with hemophilia patients. So you can see where are the 20,000 patients who are not registered anywhere, and it is now our duty that to get hold of these patients, get them registered and get them proper treatment because they are not being attended. So this is, although I was supposed to talk about hemophilia only, but I'll take this opportunity to apprise you that we have other things as well, like males hemophilia A and B is at the top, and then von Willebrand disease, rare bleeding disorders, and platelet function disorders. And we also have female patients registered with us, and von Willebrand disease is obviously at the top, and followed by rare bleeding disorders and platelet function defects. Rare bleeding disorders, they are called in the West, they are coagulation factor defects, but they are very common, relatively more common here, and the main reason is consanguineous marriages, which is a norm in our society. So this is the inheritance, X-linked, so mothers are carriers, and male children can be sufferers. Females can also have hemophilia, but very rarely. So the clinical presentations, the hematology people are actually quite familiar with it. So recurrent nose and gum bleeds, bruising, and bleeding from GIT, urinary tract, intracranial bleeds, which can be actually life-threatening, and joint bleeds and muscle bleeds, which are the hallmark of hemophilia. And prolonged bleeding after cuts or dental extraction. So we all come across these clinical presentations. For a hematologist, it's not really a big challenge, but it is a challenge for those patients who are sitting in the OPDs, and they probably are not able to identify these patients and direct them to where they can get help. So these are the some other sites, and they are important because some of them, they are actually life-threatening, like intracranial bleeds or bleeding into the mouth, in tongue or throat, and GI bleeds can be really difficult to treat. And mucosal bleeds are common. They can be mucocutaneous bleeds, as you know, they are seen in platelet disorders. Mainly generalization is there, but we do come across these in hemophilia patients also. But what is important to recognize joint bleeds and deep tissue bleeds, which are actually characteristic of hemophilia. So coming to the diagnosis, we actually have a lineup of first line investigations. We start with blood CP to rule out leukemia and other disorders like aplastic anemia, and then platelet count, and if it is normal, bleeding time is done at many centers, and then PT, APTT, sometimes thrombin time is also added. So these are actually called coagulation screen, and we are all familiar with this, but we need to do specific tests, and these are called second line tests, just to kind of confirm what our first line tests are actually pointing out. Now again, I would like to draw your attention to this fact that these first line investigations, they are available in most of the government setups, but these second line tests, they are not available in government hospitals, even the big ones. I am talking about the ones which I see in Pindi, Islamabad, like PIMS, Benazir Bhutto, Holy Family Hospital. They are really big hospitals, but they don't have facilities for these. But the facilities are available, but in the civil sector. But patients cannot afford that. It is so expensive that I think it is important that we should have the whole, all the tests should be available in government hospitals. Now coming to the management, the general management, you all know, of good oral hygiene so that dental problems do not occur, no intramuscular injections to avoid hematomas, no antiplatelet drugs because it will aggravate the bleeding problems, and then prevention by avoiding contact sports. Then nasal packing can be done with transamine so that nosebleeds can be taken care of. Then gargles with transamine. So transamine actually plays a very important role. In minor bleeds, transamine actually is used to control bleeding, and it is quite effective. And this is the traditional RICE we have been advocating since long. Rest, then ice, these packs, then compression, bandages, and elevation. And people have added prevention to it also. So this is very important, and it's actually part of the treatment. Patients start it at home and they come to the centers or wherever they can take help from. And coming to the specific treatment, I want all of you to realize that we have specific treatment for hemophilia, which is actually replacement of the missing factor. If it is factor 8, we have to replace factor 8, or if it is 9, then we need to give replacement by giving the patient infusing factor 8, 9. And then even if it's von Willebrand disease, then von Willebrand factor can be given. So we have a long list of these factors. They are human derived or recombinant, and then in the recombinant we have standard half-life and then extended half-life. So you can see a lot of varieties there. DDAVP is always mentioned in the management, but our patients usually they are of severe category. They are severe hemophilics, so DDAVP doesn't play any role in management actually. Then we have a new drug on the block, which is Hemlibra, and we have a limited experience of using that also. I'll come to that in a minute. So I've already mentioned adjuvant therapy, antifibrinolytic agents, local use as well as systemic is both very, very effective, and sometimes you can get away with using them alone, and maybe factor is not required for minor bleeds. And this is what is still the mainstay of treatment, which is available to most of our patients. Unfortunately, we are still where things were about 60, 70 years back. The West has actually stopped using these because of different reasons, but we are, in the government hospitals at least, fresh frozen plasma and sometimes cryoprecipitates, they are the only treatment options which are offered to these patients. So this is the state of affair here. So coming to the standard of care today in the West, it is prophylaxis. So they have moved on to prophylaxis, means that the patient who is in a severe category, less than 1% factor activity, they are given factor concentrates twice a week or even more frequently, and then they actually become moderate bleeders. So this prevents bleeding episodes or at least lessens the severity. So this is actually prophylaxis is the new way of treating them. But here in Pakistan, we are still doing episodic or on-demand treatment in most of the patients, because it is so expensive. We can't actually give prophylaxis to all these patients. So we are still resorting to on-demand or episodic treatment. So Hemlibra is the new drug which is being used for prophylaxis, and interestingly, it is now registered in Pakistan also. Although we don't have many of the other things which are relatively, equally important, they are not registered, but Hemlibra is actually registered with DRAP. So coming to Hemlibra, what is Hemlibra? It is a new therapeutic agent, and it is a factor 8 mimetic. So interestingly, it actually, whenever there are inhibitors to factor 8, this drug actually, factor 8, the role of factor 8 is played by Hemlibra, which is a chimeric protein. So it is used in patients of hemophilia A and B, and also those who have developed inhibitors, and also those who have annualized bleeding rates of more than 8 per year. Now, there are certain advantages, like this drug can be used subcutaneously, so that is a huge advantage as compared to IV infusions, and then it has a longer half-life, and then no risk of inhibitor development is there, and so better compliance is seen with Hemlibra. But the disadvantage is it is very, very expensive, not freely available, and cannot be used in acute episodes. So whenever there is breakthrough bleeds, you have to resort to factor 7 or some other modality. And then risk of thromboembolism. That is a problem with Hemlibra. So Hemlibra is used in very limited situations in Pakistan also, but not as much as it is being done in the West. And it won't be complete without mentioning gene therapy. And gene therapy is very much, it is being done, factor 9 deficiency as well as factor 8 deficiency. They are being treated by gene therapy, but it is a dream as far as Pakistan is concerned. We have not been able to get it done for any of patients as yet. So, as you can see, there are lots of gaps in the treatment or management. So how is that gap being filled? So there are different societies, NGOs, non-profit organizations, and some are more well organized as compared to the others. So these groups are actually working for the patients. Some of them, they have been organized by the patients, and hematologists are only helping them. So I am going to talk about our organization, which is Hemophilia Patient Welfare Society, Rawalpindi, and let me take you through what we are doing. So we have the main thing is the Hemophilia Treatment Center, and we have OPD treatment available 9 to 3 daily, and we refer these patients to different hospitals, and we give them protocols or plans how to manage minor or major procedures or emergencies. And then active role in CME activities, we are actually doing that also, and research for improving patient care. So these are all the things which are being done. And then there are certain projects we are working on. One is low dose prophylaxis. So we cannot go for prophylaxis with standard doses. So we are actually lucky to have some donations from WFH, which is a collaborator with us. And we have actually very good results with low dose prophylaxis, but obviously in a very limited number of patients. Similarly, emicizumab also has been tried in some patients and with very good, rather excellent results. But obviously, again, it has been done through donation, and very limited patients have benefited from it. Then home therapy, as you can see, it is important that these patients should start treatment as soon as they start bleeding. Some of the patients, they live in far-flung areas, so it's good that they have factor at home and they can self-infuse whenever there is a need, because coming to a center might take up to a day or at times even more than that, and then the damage is done by that time. Then we have hepatitis C as a problem, because our patients who are using FFPs and cryos, you can understand that they get hepatitis C. And then joint health is a major issue, although we try to do our best, but still patients are suffering. So we refer to them to physiotherapy centers so that their joints actually remain healthy. And then mental health. And as you can see, I have also put it at the bottom, although it is a huge problem. Patients who are suffering from this lifelong disorder, they have psychosocial issues, boys as well as girls. And we recently have started treating them for these disorders also. So how we work? We work with the help of volunteers, consultants, hematologists. Patients themselves are very active. Relatives of patients, then members of society who want to contribute, then patient youth groups, women group, they are also very active. They make support groups and guide the patients where to get help, and obviously they console each other. So that's a good way of taking care of them. So this is a list of all the hemophilia friendly hospitals we have in Pindi, Islamabad. And these are the products which are available for our patients, and on-demand episodic treatment. And how they are available, the government is not providing them. They are being bought by money, which is kind of people donate, and this is how we get. And in the second line, I have mentioned donated factors. These are the ones which are donated by World Federation of Hemophilia. So these are the ones which are available in the open market. These are the ones which are registered with DRAP. And you can see only 3 of them are there, and they are really, really expensive. So we can't afford that. So we go to the last list, which is actually buying it from the parallel market, and which is illegal, but since it's life-saving, so we have to resort to this illegal activity. Then treatment plans, obviously, patients actually shy away from taking care of these patients. The dentists, the surgeons, the gynecologists, they get scared that how to deal, especially once they start bleeding. So they need some help, some reassurance. So we provide that. We provide them these kind of plans so that they can take care of these patients. And life-threatening bleeds, they are a real challenge, and they need a lot of support. So these are our donors. You can see international donors as well as local philanthropists, friends and families, and sometimes Baitul Mal also helps if they have funds. The other activities which we are doing all the time is CME activities for the residents, for the doctors, for the healthcare professionals, and by seminars, symposiums, since I teach at a medical college, so that is one part of my activity. And awareness programs. So this awareness is done through these educational material which we have developed, and these are these booklets. They can be very helpful for people who are doing house job and even our residents. And workshops for caregivers, how to help and what to do, that is important. CME activities, you understand, that is again very important. Now coming to a special need of these patients is self-infusion. So we actually try to help them learn how to self-infuse themselves. So if they have factor at home, they can infuse themselves. So home therapy is an important thing. In the West, it is a norm. They take the factor home and they actually infuse themselves and do all the normal activities. Here we don't have that much factor with us. So we only offer it to people who are living very far off, like in Gilgit-Baltistan or Kashmir. So very limited home therapy we can actually afford. So complications of joint bleeds, that is the main problem with hemophilia patients, and they need to be taken care of to avoid disability. And for this, rehabilitation and physiotherapy is important. And we are lucky that we are affiliated with AFIRM, which is Armed Forces Institute of Rehabilitation Medicine. And also at Benazir Bhutto, the physiotherapy department is actually working very closely with us. So we do refer these patients there. And for management of inhibitors, we are lucky we don't have that much inhibitors as we see in the Western literature. So Novo-7, FIBA and Hemlibra, these are the choices which are available for dealing with these patients whenever they develop inhibitors. And as you can see, it is very expensive to treat them. So what we need to do, I would like to share my request with you, that we need to spread awareness among public healthcare providers with the government, and so that these patients can be identified and they actually have access to hemophilia treatment centers. And these treatment centers should be in government setups. And then genetic counseling is important because, like I said, there's some of these disorders, the rare bleeding disorders, they're autosomal recessive, and cousin marriages, if they are avoided, these can actually be kind of prevented. So we need to actually ask our government to get diagnostic facilities at tertiary care hospitals at least, or DHQs even better, and standardized treatment in government hospitals. So in the private setups, many patients, they are being looked after adequately, but actually the government hospitals should be taking the lead. And then facilitation of import for these factors at the moment. If not, we cannot make them soon, so we can actually get them from where they are made. And then inclusion of these factors, because you can understand they are actually life-saving. So I think it is fair enough that these life-saving drugs should be on the list of all hospital formularies. So once the patient lands there, they don't have to run for help to these private organizations, and they should be treated in the government hospitals. I'm not against the private setups, but then majority of our patients, they can't afford to go to those, so they should be treated in government setups. So regarding management, obviously one should be able to assess the severity, and much depends upon what choices we have. Unfortunately, they are quite limited. So I thank you for your attention. If you have any questions.
जितने आपके पास रजिस्टर्ड पेशेंट हैं,
Yes, yes.
उनके लिए ट्रेडिशनल ब्लड बैंक प्रोडक्ट्स के ऊपर कितनों को स्विच करना पड़ता है?
The supply of these factors is not a regular affair. As I said, that we get donations from WFH. So during the COVID time, we were not getting any factors. So it was 100% reliance came back to FFP and cryo. So we didn't have anything at that time. But in routine times, those who come to the centers, they are relatively better off, because we actually provide some factors also. So if they have some emergency situation, we give them factors as well as FFP and cryo. So maybe at that time about 20 to 30% reliance is on these blood products and mainly factors. But since we don't have free access to these factors, so we are all the time trying to save factors and giving them the lower doses. And even if you look up the new recommendations, the guidelines for treatments, they actually have mentioned the dosage for resource constrained setups like ours. So we can actually take help from those. So, and interestingly, these are relatively lower strengths of factors. They work quite well in our setup. Like the percentages they mention, if they are saying that 80 to 100, so maybe 70 to 80 is working fine for us. And the reason is not a personal choice, it is because we don't have that much factor to go up to that limit. TTI तो अभी हम इतनी नहीं कर रहे क्योंकि yes, it needs a lot of factor also. Yes.
For this therapy, like कि कौन लोग होंगे जिनको आप emicizumab के लिए select करेंगे कि इनको देंगे prophylaxis, and then how do you what is their quality of life with that? कौन क्या young हैं बहुत या बड़ी उम्र के patient क्या inhibitors के साथ हैं? How do you select your patients for that?
This emicizumab was actually started about 2-3 years back, and at that time the WFH actually put down the selection criteria also. So their first choice was inhibitor positive patients who were less than 12 years, and also then inhibitor positive patients who are more than 12 years. That was their first choice. But then they extended the choice to patients who have ABRs more than 8 or intracranial bleeds, severe bleedings which can be life-threatening. So we now actually are dealing with all these categories, and it is a choice with us also, with Hemlibra being registered in Pakistan. So there are certain NGOs who are also helping in this, but mainly our donors are WFH, so we are doing with the donated Hemlibra. So our results have been excellent, and one of our patients has actually undergone this knee replacement, and you can imagine. So we were not I was at least not very enthusiastic about it, but then he was adamant to have it, and luckily he did very well, and he is walking around, mashallah, and very confident. So the results are amazing. But what is important here and what is comforting is that you do the loading doses and then you start on these patients on maintenance. So compliance is very good. आप महीने बाद ले सकते हैं, 2 weeks के बाद ले सकते हैं. So you can imagine, and then sub-Q injections actually makes it much easier. I think Aisha wants to add on to it. कुछ कहना है आपको?
Just to share my experience with imosuzumab, because I think we have around 34 patients that those who are on imosuzumab at the moment with the society that is being supported by Dr. Chotai ever since like 1998. And it's his baby, and it's all the time attached. So my students and myself are all the time involved with those patients' care with Dr. Shaila. And these patients were obviously, as Dr. Lubna has mentioned, the selection criteria was initially laid down by the World Federation of Hemophilia Humanitarian Aid Program. So according to because we did not have any support for those patients who had inhibitors, so the other patients, otherwise with patients who are hemophilia A or B, we get those factors in quite a good quantity. So they said, so you first select all those patients who have inhibitors. So we all together work for that. For the patients, for the inhibitor screening was done on all those patients who were registered with the society, and all that were there were some new registrations, some metastases were done, and quantification was also done. And then since we had some more patients, so they also allowed to add as those patients who were non-inhibitors, like with high ABR and severe bleeds. So all those patients, obviously, they are very they show excellent results, and there is no doubt. So all the data has all the supports for imosuzumab. So there is hardly any bleed. The compliance is better. All those patients of inhibitor, there is a transformation of their life, totally a game changer. So and one thing to add, that we cannot, in case of a breakthrough bleed, or whenever there is a breakthrough bleed, we have to give them recombinant factor 7 instead of prothrombin complex, because that would add on to the risk of thrombosis as it does otherwise. And those who have to go on for surgery, we have to give them factor 8. One problem is still prevailing as how to monitor those patients, because they cannot be monitored by the regular factor assays, one stage factor assay, and we have to do chromogenic factor 8 on patients who have hemophilia A, and use bovine factor 8 reagents for those who have inhibitors. So it's still on its way, and I hope we can better manage those patients, since it's there and it's approved by DRAP, and it's going to be used on these patients in Pakistan now.
Thank you, Dr. Lubna, for such an enlightening talk and detailed discussion of hemophilia patients. Our next presentation is by Professor Dr. Han. He is the Deputy International Commissioner of the College of American Pathologists, as well as visiting professor in Mohammed bin Rashid University and Vice President of Emirates Pathology Society. This presentation is online, and it is about the pre-analytical phase at emergency care. Thank you.
Can you hear me now?
Yeah, now we can hear you.
Thank you so much for the invitation I'm sorry I cannot be there live in person to join you in, one of my favorite cities in Lahore and to join my esteemed colleagues. Today I will be talking about pre-analytical phase and quality issues, specifically as they apply in the emergency care setting and a new multi-pronged approach to improvement. So the agenda, we'll look at the pre-analytical stage, some of the definitions of this phase, some of the facts of issues that pertain and lead to quality specimen, for issues that are unique and probably more noticeable in the emergency department setting, typical errors, how they concur, the impact of these errors, and a process for improving the pre-analytical phase. As we know, the lab diagnostic phase is typically divided into 3 stages: the pre-analytical, before the specimen arrives for testing. The analytical stage typically is the most consistent, especially in this setting where we have accreditation and external quality assurance, as well as robust quality control schemes. And then the post-analytical stage, much of this surrounds communication of results, as well as follow-up testing and other incidents that after the results have been verified. The lab's importance is a high priority, as we know, and the theme of this year's conference is aligning post-COVID. During COVID, without the lab, it was nearly impossible to get out of COVID. But even post-pandemic, the lab contributes, in many cases, over 70% or 80% to treatment decisions, because without a diagnosis and the proper diagnosis, there is no proper treatment of the patient. So the lab is critical in the ability to care for the patient. The pre-analytical stage typically contributes the most problems and incidents as it relates to lab testing. So 70% of issues, nonconformities, outliers, or incorrect results is typically prior to the specimen getting to the analyzers. That number can be as high as 70%. So most of the issues have to do with that phase, the first phase of testing. As you know, it could be due to handling, collection issues, storage, preparation of the patient. Many of these are surfaced in accreditation. One of them I'm involved in is Joint Commission Hospital Accreditation. So one of the patient safety goals is identification. That can also be a significant performance bottleneck. Sample collection, centrifugation and preparation, storage and transport, as well as handling prior it is analyzed. So these are all pre-analytical issues that can impact the quality of your lab performance, the quality of your result. Getting the wrong result, but the wrong patient ID, or a poor collected sample, insufficient, or sample that needs to be rejected impacts lab quality. In the emergency department, in hospital settings, this often is one of the weakest links, and some people refer to like it's the soft side of the belly. Many issues can occur here. Some of the issues relate to blood collection. Some can have increased hemolysis because of the practice and use of the collection through either IV cannulas or tubes. High hemolysis rate also can be more associated with full draw tubes. And this is a big challenge and often frequently occurring problem. The collection technique can be a source of the problem. And in most hospitals, the ED, the emergency setting, is one of the areas, typically because there's a turnover of staff. The other areas we see this is also in ICU settings and also with pediatric patients. But generally, the emergency setting in a healthcare setting, in a hospital setting, is where we see a lot of our pre-analytical issues. If you practice in a non-hospital setting, often I see this when you have an outside lab with multiple remote collection sites. So the transport and the collection at the collection site and then having a quality specimen. Some of the issues also can overlap with ED settings. Let's look at some of the impact of pre-analytical errors. So pre-analytical errors can have financial outcomes. The picture on the right-hand side shows an iceberg, which is the example and trying to demonstrate that pre-analytical errors we may see, but there are a lot of underlying problems and they can impact the total test process. They may lead to retesting, redrawing of specimens. They add to staff labor costs, the amount of time that staff needs to dedicate to testing. There can be waste of precious blood, and this can be especially important in specific patient population, and it can impact the treatment costs in patients. So these are some of the ways in which pre-analytical inefficiency or errors can impact healthcare costs and spending. When it's estimated in America, these are some of the numbers, and I want to acknowledge the assistance of Dr. Maria Agafonova from Griner, who helped me do some of the research with many of these specific examples. Inpatient, in the critical area, so in the ICUs, maybe a neonatal setting, these are the impact. For outpatient, it is also a significant number. This includes patients treated in the emergency setting. Now, if you're in a sizable hospital, and this is pretty sizable in the US, in Pakistan, this is probably a medium-sized hospital. And if the total pre-analytical inefficiency or error rises to 1%, then the added cost can be above $1 million a year for that hospital. How do we improve the pre-analytical process? Once again, the vast majority of issues will occur prior to the specimen arriving into the lab, so during this phase. And variance in practice, it is because nursing staff and not laboratory staff is involved in obtaining the blood. They usually have different systems for training, competency assessment, and oftentimes we also see variation in how the performance of nursing staff does occur in settings. The collection of the blood has to be appropriately done, and often there are mechanical improvements that can contribute to better pre-analytical quality. And one of the things I will talk about now and I'll emphasize later, it's very important that when we work with vendors, we choose long-term partners that can help us with all three of these processes, with training, with standardizing operation, as well as providing us with some of the best mechanical as well as equipment to optimize our pre-analytical collection process. So one way in which training and standardization can impact ED blood collection, sometimes the lab procedure may be more familiar to lab staff, but if your phlebotomy staff is not lab employees, they may not be as familiar. They may be trained on a different SOP, or they may be trained against the actual practice of whoever their manager is, but it may not be best practice. And oftentimes there has to be interaction, there has to be ongoing conversation and dialogue between the lab. Usually the ED chief has to be able to support and be the leader, as well as the nurse manager, to have good communication between departments as well as within the department. This dialogue also helps educate staff about specific information and data that can lead to identification of the problem. Sometimes we have to do a deeper dive. We may have to do a root cause analysis to address what is the reason for not having quality specimens or having problems with pre-analytical issues. When communication is ongoing, it can improve relationships and usually better implementation of standard procedures. Sometimes we only see moderate improvement overall, especially with the quality of the samples. And usually one of the big pre-analytical issues is specimens are hemolyzed. They're hemolyzed specimens. And dialogue, communication, and using standard processes cannot fill the entire gap in performance. And this has to be ongoing because oftentimes with staffing, especially with challenges in staffing different departments, there may be turnover, there may be cross-training, there may be personnel deployed to multiple areas. So ongoing training, ongoing proficiency evaluation, and competency assessment is important. In most of the places I practice, every 3 months, we usually have to do another training exercise. Either it's a new batch of nurses, it could be new phlebotomy staff, and we have to always be continuously vigilant. The right tools for blood collection is important. The IV catheter usage, hemolysis rate, can relate to the vacuum within the tubes. Partial draw vacuum tube collection systems can help improve the hemolysis rate and make it less of an issue. So hemolysis and hemolyzed specimens as a source of rejection is probably one of the frequent reasons that we reject specimens. The other one tends to be around patient identification. Partial blood tubes also can decrease and optimize the amount of blood that is drawn from patients. And this can be important in specific cases in specific patient populations. In one study with patients with acute myocardial infarction, partial blood tube is improved in terms of the total blood volume that is taken from patients. So reducing the incidence of anemia that is iatrogenic or hospital acquired as opposed to larger volume samples, possibly only for 1 or 2 tests in specific patient population. Some of the characteristics of these low volume tubes, they tend to be standardized. They're color-coded samples, and the additives are specific for the types of testing. They have very stable shelf life, and they are compatible with virtually all of the common instrumentation that you would be using. They're optimized with the appropriate ratios to minimize the blood draw and to prevent acquired anemia from hospitalization and repeat large volume blood draw. The type of collection system also can be impacting possibly disproportionately, especially in the coagulation testing setting. So for the hematology lab, if you have coag studies that are done in the lab, it's very important to have the appropriate volume to have quality lab results for coagulation parameters. Underfilling of the tube can be prevented by using a discard tube so that your first tube may be underdrawn and you may need to use a discard tube in order to optimize your coagulation results. And typically we would not recommend your first tube be a coag tube. Prompt mixing of the sample is very important in order to prevent clotting due to poor mixing. And there are tubes that are optimized for a specific platelet type study to prevent platelet activation. One of these tubes is a CT8D tube that has reagents to stabilize platelets for additional platelet studies that may be needed. Sometimes these are not issues that pathologists may be aware of or we look into, but the construction of the tube can be very important. So the construction and what actually goes into the tube in the tube walls is very important for the appropriate concentration to maintain these, to optimize and inhibit especially in coagulation studies, platelet preventing of the activation, to optimize the mixing and the mixing of the reagents and the blood volume. The correct volume and the maintenance of the right vacuum also can be dependent on the type of tube construction. So these, in addition to communication, the optimization, and having the right materials in terms of the types of tube. I know this is a hematology session, In chemistry, we often will also use plasma-based tubes. I've done this in several hospital lab settings, conversion to plasma-based collection. There is some work that goes into the validation of this, but there's much benefit to be derived. And oftentimes, the validation is fairly straightforward when you compare serum-based assays and plasma source assay. And often the sample quality will improve, the turnaround time will be decreased, and fewer aspiration errors. So when possible, that is a way to get improvement, especially in the chemistry lab setting. The catheter can also improve performance. Obviously, I'm sure you've dealt with different types of collection system. Usually we're concerned about safety of the collection device, preventing needle stick injuries, and also the type of catheter, minimizing hemolysis, having standard adapters so they're universally able to use these. These type of catheters also have very standard back-end adapters to be able to optimize and make it more efficient to collect blood from catheters. And it fits all of the vacuette holders as well. So they're very useful and adaptable. There's also safety devices that allows easy transfer from syringes that are sterile. They're packed, single pack type of blood transfer devices, and also with standard connections and locks, reduces the need for needle transfer directly into the tube. So here you have the syringe with the transfer device and the specimen tube that's all connected in an easy to accomplish transfer from syringe. So in conclusion, we talked about how the pre-analytical stage is often one of the more complex and error-prone areas with multiple steps in the process. It's important in your setting to identify what your key sources of problematic pre-analytical steps are. The cost may be hidden, like the lower part of an iceberg, and the impact can be sizable. So it's very important that we identify the sources of pre-analytical errors. The reduction of these errors is possible, but it requires good analysis, having long-term partners that can be available to do process analyses, to look at partnership in training, as well as provide the best mechanical and collection devices. So it requires a multi-pronged approach, standardizing your practice, training, and you never stop training. Having the right tools, communication within the lab, between the lab and other hospital or other departments or other settings in your practice environment. And that brings me to the end of this talk. Thank you so much for your attention.
Different steps of pre-analytical error and elaborating the damage it can do to the laboratory industry. Now I invite Dr. Nazis Saklan, Associate. Any question answers, please?
Thank you, Dr. Arun. It's always good to hear you on the quality control. So thank you so much for the amazing presentation. My question is regarding delta check in the hematology lab, because hematology can use CBC as the delta check for identifying pre-analytic errors. Do you have any suggestions for doing delta checks in coagulation laboratory for picking up the pre-analytic errors like wrong adressographs or wrong blood in the tube? Thank you.
Yeah, delta check is useful. I have less experience in the coag setting. If you do have consistent draws, most of our deltas probably occur more obviously in the outpatient settings than in the inpatient setting, but it can be a way for error detection and patient identification help. Actually, most of the time where we have patient identification issue, it's at the time of drawing. I teach health system improvement in the medical school, and I tell patients, oftentimes you may have standard procedures, but people try to do things efficiently. Sometimes they'll take a shortcut. So every once in a while, fortunately our staff are very honest, but oftentimes, for example, in the emergency department, to make it faster, they'll put all the tubes for all the patients in one bucket. They'll line up all the patient stickers, they'll draw all the bloods, and then they'll label the tube. So I've had that happen. We've had to reiterate, you have to slow down and get the identification correct, because if you have an error, it's not impacting just one patient, every patient in that draw. So that's my other comment, is if you detect an error on any given day, go back to those 2 hours of testing, find out that location and do a deeper dive. Make sure there was not a system error that took place, and it's not just a single isolated issue. So always think about your system, where it could go wrong. Oftentimes when you have an error, it's not just a single one. Isolate the date and time and also the specimen location to make sure it wasn't just an isolated case. But I really advocate delta checks. The other one where you typically have high volume, and to the extent that you can use moving averages is a good way to also have real-time quality control. You can usually pick up small, minute changes when you have large numbers and you track the moving average and the trend. Because, you know, even though I'm an advocate of EQA and CAP, most of the CAP information, it's too late. It's 3 months, it's months after you submit it. So EQA is late. So the only way you can be preemptive is you need to have other ways to pick up potential errors and mitigate these. So delta checks as well as moving averages is one of those ways. And obviously real-time onboard QC, and when you have a system like many of you practice in large lab systems, you can then also compare among your different labs and your performance. So if you have one location that's out of range, usually that requires a deep dive. Because if your system processes, and I know your systems, they're very uniform and you've educated your staff, your quality is cascaded throughout your system. So if there's an outlier, you need to be aware of it, because usually it's a process issue, training issue. Good question, thank you.
Thank you very much. Any other question, please?
And I will stay on, so if you do have the panel time at the end, I will stay on.
Thank you. Now I'll invite Dr. Nazish. She is Associate Professor and Consultant Hematologist at the University of Child Health Sciences, and she will tell us how to maintain quality assurance in bleeding disorders.
My dear teachers, my mentor, and my very dear students, Assalamu alaikum. And I, as Dr. Humera has said, that I'm working at the University of Child Health Sciences. I was given a mammoth task by the organizers of PAP. I'm very, very thankful to them. And I'm very thankful to Professor Han as well, who has minimized my task to some extent. I will try to be brief about it. I have nothing to disclose. So whenever I am studying any topic or I am trying to present something, it always rotates around what, why, how, and when we are going to do it. So same applies to the quality assurance and quality control when we are talking about in diagnosing bleeding disorders. And first of all comes why. Why we do want our tests to be reliable, and as we all know that in the healthcare system, we are dealing with the patients. We all want our patient to be safe and to be healthy at the end. Medical error, that is an unintentional act, obviously. If it's intentional, it's not an error. And in 2000, a report came from the US Institute of Medicine, which said that greater than 1 million preventable errors occur every year in US. And we don't have any data in Pakistan. या तो हम कहते हैं सब अच्छा है, या हमारे पास रिपोर्ट नहीं होती है. But medical errors also include diagnostic errors. When we are doing our work in the laboratory, that is the major issue where the diagnosis of the patient depends. And these errors account for around 9 to 15% of the errors. And obviously, when there is an error, what will happen? We are going to have an increased turnaround time. We will be delayed in the report delivery. There will be inconvenience resampling of the patient. There will be an increased workload. There is a repeat testing. You can imagine when a lab is going to call you and said that we have some problem, you have to give the sample again. What will be your response on that? And obviously, it will affect the patient well-being at the end. Talking about the coagulation lab, we are performing the diagnostic as well as the test which we are doing for the monitoring of the management of the patient, like the heparin therapy or warfarin therapy. So what do we want from our coagulation assays? Obviously, we want them to be precise, accurate, robust, and we want to produce the reproducible results. And how it will be done? That will be done by following the good standard operating procedures. We should be having effective QC practices and controls. Now, when it comes to the quality assurance and quality control, these are two terms. Actually, this quality assurance is a bigger umbrella under which comes the quality control. As you can say, quality assurance will cover everything. That is coming right, your building, your HR, your people, and then your testing lab. And then comes the quality control, which is a series of the measurements which we are doing. These are the practices which we are doing on daily basis, even with every batch, in order to maintain that quality and assurance. So one is the system and other is the tool which is leading to you towards that system. As we have already said, quality system basics, that involves a lot of things. So we know that why we are doing the accreditations. Why do we need audits? Because we know people do what is inspected, not what is expected. हम भी नमाज तभी पढ़ते हैं जब हमें कहा जाता है कि आखिरत में पूछा जाएगा, वरना शायद हम ना पढ़ें. What is expected and by whom? We know that यहाँ पे consumer कौन है? The consumer is our patient, our clinicians, and our health organizations. And the producer is the laboratories who are doing the test and they are then delivering the reports. In 1999, this was the hierarchy model of quality goals that included clinical outcomes, biological factors, clinicians' opinions, professional recommendations, proficiency testing or EQA, state-of-the-art facilities. And in 2014, this was reduced to the first three. That was the clinical outcomes, biological factors, and the rest of the three were included in one goal. Basically, when we are dealing with such kind of parameter where a physician orders a test, the patient and the lab are aware, we need this kind of model where every stakeholder is on board. Then comes the quality control. There are two types, internal quality control and external quality control. So internal quality control is the procedure which we are doing. This is the continuous evaluation. You are doing it with every batch, maybe on daily basis. And external quality control where some external body is concerned, who is going to send you certain samples, you are going to test them, you do not know the value, then you resend them, and this is the comparability of the in between the labs. This can be done regionally, nationally, or internationally. Like ECAS, NECAS, we have different EQAs. Whenever the test process comes, you are going to order a test for a patient. We all know that, and Professor Han has beautifully explained it as well. There is a patient, there is a test ordering, the patient has come up with a certain symptoms, maybe with the bleeding, and the clinician who is looking after the patient, he is going to order certain tests. There is sample collection, transport to the lab. Then there is order processing, the analysis of that test, report is formed, and finally it is given, and then the decisions are being taken on the basis of your report. So three phases, we all know that: pre-analytical, before reaching the lab; analytical, when you are actually testing that sample; then comes the post-analytical, when you are going to report it back. Pre-analytical phase has further two sub-classifications, that is outside the lab and within the lab. As you can see from that cycle as well, there are certain pre-analytical things which are done outside the lab, till the sample is taken and then it is transported. And before the test it is processed, that is within the lab. There is also a pre-analytical, which we can easily say as a clinical pre-analytical phase, where the physician is deciding what to do, which test I want. And then we have the lab pre-analytical phase. Similarly, in the post-analytical, we can divide it into the laboratory and clinical post-analytical phases. Majority of our errors, that is around 2/3, even more than 3/4 of our errors, these are actually pre-analytical errors. In any of the lab and even in the coagulation, the majority of the errors which are being reported by literature, these are the pre-analytical errors. And among them, the most common one were the misidentification, mislabeling of the sample, and the hemolysis. Then comes the analytical errors, where your reagents, your performance of the test and everything occurs, and then the post-analytical inappropriate reporting. And we can also say that this pre-analytical error can cost a lot. So I can see a lot of residents over here, which is a good thing, because when we are talking about any of the topic, we have to move in the real scenarios. So these are all the real cases. This was a case which was coming up from the cardiac surgical ICU, and she was a 12 years old girl with a cyanotic heart disease. Actually, she was traced back because she was having a lot of FFP requests to the blood bank. We need FFP, and when we look into the data, there were many other patients who were frequently transfused with FFP. And when we talk to the physicians, what is happening over there, they said they all have the higher, they have the deranged coagulation profiles persistently. And we have to give them FFP because we have to plan the surgery and everything. So this was the thing. And when I asked, is there any history of bleed? They said no. No history of bleeding in the patients, no family history. So what is happening over here? When we looked into the data, the CBC showed these two parameters. When you have cyanotic heart disease, you have polycythemia. So we know that this is one of the pre-analytical errors which is important in coagulation, that is your hematocrit. So if you have a high hematocrit, what happens? Yes, exactly. Actually, you are getting less plasma in respect to your anticoagulation ratio. So as a result, clotting will be deranged. आपका anticoagulant उसको clot नहीं होने देगा, so you will get the higher results or the deranged clotting profile. And when we did the anticoagulant adjustment, it all came fine. And we had a lot of plasma which was saved to that point. And these patients were not exposed and now are not exposed to this excessive exposure of plasma therapy. And when we talked to them, they said, okay, how we are going to do it? We can't do it. So we said that you can send the CBC reports of these patients at least to the lab before collecting the sample. And for the resident, these are the two formulas for the collection of the citrate, how you are going to adjust your anticoagulant. This is the formula to calculate the residual citrate in your tube which you are going to leave before taking the blood. And this formula is used to calculate the volume of the anticoagulant you want. ठीक है जी, एक में आप निकाल रहे हैं, एक में आप उतना डाल रहे हैं. Case number 2, this girl also presented from the surgical department with choledochal cyst, that the cyst was quite huge and the liver was also involved. She was on the post-op day. There was history of bleed from the drain site, for which she was giving FFP. And the complaint again was the persistently high, the deranged coagulation profile, PT, PTT, INR, they were all deranged. And again, as Dr. Bushra Muiz was talking about the delta check, and when we look at this, we do not know whether it is the pre-analytical, analytical, or where this error is happening. Because in 3 to 4 reports, there were the normal, they were deranged coagulation profile, and one of the reports suddenly came up with the normal coagulation profile. And they were like, we are going to go for the surgery, how would you do it? So they requested for the factor SS. We suspected of the liver function as well, that was compromised. But when we did the factor SS in the first time, only factor 10 was lower. So either we are going to label the patient as the factor 10 deficiency. That is again a big label which she is going to carry for the whole of her life. And then the test was repeated. Then we came up with the factor 7, 9, and 10, they all were reduced. So showing that there was some liver pathology which was going on because of that choledochal cyst. So again, there was a history of fresh frozen plasma multiple times before taking the samples, and which was being not mentioned, and the test was done. So coming back to the post-analytical error, a number of the errors और उसके अंदर जो हमारे doctors की handwriting है or the use of the terms which are not established ones, that is very important. Now, how to establish this quality control? There is a cycle of this quality control, which says plan, do it, check, and act. If you have the ideas, but you are not using them, they are useless. So whenever you are going to plan for a quality control, there is an initiate. You are going to assess your processes. You are going to plan. You make the documents, how you are going to do it. You implement them. How do you implement them? By your staff, your systems, your processes, and then you keep on monitoring them, you evaluate, check them. This is a continuous assessment, and you have to look for the gaps, shortfalls, or failures. If you get a report of a shortfall one time, two time, but you are not doing anything about it, so what's the fun of doing the whole cycle? What are the key indicators which we can follow in the coagulation lab? Thresholds should be meaningful and doable, achievable. If they are something like that we cannot achieve, they are useless. In the pre-analytical stage, the most important is the sample. And we can see that if there is a short sample, because these are all preventable errors. Short samples, hemolysis, time to be processed, and particularly pediatrician, neonatologists, they are the real offenders in that, because they feel offended that you are asking for the sample from such a little baby again and again, because the tubes are often underfilled. And the one more practice they do, when we send it back that this is underfilled, they are going to mix the tube by opening up the cap. So the patient is going to, or the attendant is going to take it back. Now it is properly filled. So you have to see what they have done in that condition. Analytical, we have to see why there are certain tests being ordered, because certain times at one time, actually this was a real case, that excessive amount of factor VIII was coming up in the lab. And why? Because any patient who was presenting with the bleeding, apart from any history which is correlating to hemophilia, he was being suggested to have his factor VIII done. So we have to see why this is happening. Rejection logs, again, Dr. Han has already said about this thing, that the wrong tubes which are being sent or tested. Turnaround time is very important, because in critical care, your turnaround time will be different. For elective tests, your turnaround time will be different. If you are doing the screening test, it will have a different turnaround time. And if you are going for the definitive test, you have to follow that. In the post-analytical phase, we have to look for the flags. If your report, your analyzer is showing any flags, you have to take the actions. These are the guidelines from the International Council for Standardization in Hematology, particularly for coagulation as well. And they have said these few things. Ordering test, how you are going to order it. Then comes the sample collection tube and anticoagulant, which we are going to use. We know that for sample collection for the coagulation, we are using the blue top ones, which have which anticoagulant? Trisodium citrate in the concentration of 3.1 to 3.2%. If you are going to use it a higher concentration, that will be a very strong anticoagulant. So your test will be deranged. And why we need the anticoagulation? To prevent that clotting. Otherwise, your sample will be clotted immediately. Then comes the preparation of the patient prior to collecting the blood. If the patient is coming up from a gym with a heavy strenuous exercise, or he's under the stress, your factor S's will have the impact. And particularly in that condition, fibrinogen, factor VIII, these are all acute phase reactants which will be raised. Blood sample collection device, this has already been talked about, and we are going to use the needles which do not cause the lysis or the activation of the clotting factors. Particularly the very narrow needles, they lead to the hemolysis or the activation of clotting factors, so you need a certain bore of needle. For adults, that ranges from 19 to 21, and for pediatrics, that is 23 to around 23, that is enough. And if you are going to take the sample from the butterfly needle, which is often happening in the pediatric population, so you are going to discard a little volume of it, and then your coagulation tube will be the first one. Venous stachys, if you are going to apply the tourniquet for a long period of time, again there will be the activation of the clotting factors. That should not proceed more than 2 minutes. This is the order of the tubes which you fill. You often tell your other colleagues that please collect the collection tube before the other tests are being taken. So the processing of the sample is also important. If you are going to receive a sample and you just leave it and you are going to do it afterwards, your coagulation results will be deranged. If we are using certain other plasma anticoagulants, or you are using other samples, what will happen? In EDTA plasma, what happens? EDTA is a very strong anticoagulant. Whenever the strength of the anticoagulant increases, your coagulation profile will be deranged or prolonged. And how this will happen? There may be the contamination. Contamination of the tube. If you are taking multiple samples and you have taken the EDTA first and then you are transferring it to the citrate tube, you might have this contamination. And serum, if you are using it, what happens with the serum? Serum doesn't have fibrinogen. So this is not going to clot. Fibrinogen factor 2, they all will be low. Similarly, certain other processing, and the most important is this, freeze thaw. This do happen in the coagulation lab. Like you have taken the sample, you have processed it in time, you have frozen it into the allocates, and afterwards you have planned certain testing, then you have put it out on your bench, and there is a thaw process, but you have left it for a long period of time in your water bath or on the shelf. So what will happen? This freeze thaw mechanism will also lead to the deranged coagulation profile. When we come to the internal quality controls, what happens in that? Internal quality control means that we are applying certain controls. We have these controls are the substances, we know them, their values, and they are similar or simulated patient samples. Like there is a normal control which is giving the normal values, low or high control. Then the duplicate test on the proportion of samples is carried out. There should be a consistency of mean values of patient data, correlation checks, and delta checks. Correlation checks, what are these? That your results should be correlated with the clinical condition of the patient. The different methods are correlating with each other. Delta check is old reports of the same sample within a few days, they should be correlating with each other. This should not be like that one day before you have a prolonged coagulation profile and in the next few hours you have the normal coagulation profile. QC procedures we have already talked about. So this is the diagram and the terminology. I know this is a very dry topic, and there are certain things which we know and others we don't. And this is the diagram which you all have seen. Teer kaman or arrows ke saath kuch, there is a bullseye. What is that? The accuracy, which is closeness to the true values that you have assigned, close to the absolute values. Then comes the precision. You are getting the results again and again, which are reproducible and they are repetitive fashion, they are giving the same results. And our goal is the accurate and precise. And when we are not accurate, there is an element of bias. So we have already seen precision, accuracy, error. When something is not going right, there is a random error which is not predictable, systematic error which occurs in a consistent, repetitive fashion, and we have to take the action immediately. For all the tests, we have the upper and lower limits, and in between that interval is your range. Robustness or ruggedness, that is the ability of your analytical method to withstand the minor procedural changes without affecting the overall performance. Like you have a factor assay or you have a PTA PTT which is being you are doing on the automation, and there are multiple technicians who are coming in different shifts, so your results should not vary with that. Certain other terms. What is the standard or a reference? With the standard or a reference, you have a solution with the known value. You know that in that solution, I have 10 international unit of a factor. And the laboratory controls, these are again commercially prepared or in-house. We know that controls we are running with the different tests, maybe daily basis or with the shifts. And there comes the validation. When we validate our procedure or an instrument. Anyone? When we are going to introduce something new, we need validation. If something is running, it's going on, we need calibration according to the time. So first of all, if there is a new method, you need the validation. And before that validation, it is not going to come into the routine. And this validation is your specifications with the already running method or with the gold standard method, right? And your new method should be more precise and more accurate. So after validation, you are going to do the calibration. Once your instrument is calibrated, you are going to run the control and then you run the plasma or the test sample. It's just like an example, if you are going to take the height of the people against the wall. This wall is like your equipment and you are going to place a scale across that wall. This scale is your calibrator, which is giving it that this number is the 1 inches, 2 inches, 3 inches. So your calibrator is telling your instrument that this is what you are going to read, and then you are going to apply the controls. You have certain things with you, like this table or a chair that of this height. So when you are going to test the different people with the unknown height, now you are going to tell what is their height. So another example is that when we are talking about, we have talked about the pre-analytical errors, right? So when we are talking about our analytical ones, we have to understand our reagents, our equipment, what methodology we are using. For example, a 16-year-old male, he came up for some surgical procedure, and he has a family history of bleeding. His PT and APTT screening tests are normal. Will this patient bleed? Are you going to test him further? And what is the most important information when evaluating if the patient will bleed? This is the normal questions that the surgeons do ask from you. So looking at the APTT factors, because इसके अंदर क्या एक important history है. There is a history of family, history of bleed. So you should be looking into the other factors. So if you are going to apply these factors, his factor 11 came out to be lower, in the lower range. So there is an abnormal factor 11, although he didn't have any history of bleed. The family history was positive. So the patient is deficient in factor 11. So what your reagent has done, your reagent of APTT didn't pick it up, right? Your APTT wasn't prolonged. So there is a factor 11 sensitivity test. How you can do the sensitivity? If we take the normal plasma and the deficient plasma is added, activity is being added, and then we see how prolonged is the APTT is going to be. And then you can see that only in the last reading APTT is somewhat prolonged from the upper range. So this is the level of the factor activity at which it is going to pick it up. So in the factor assays, when we give the ranges, this is usually the 30% range that we consider it as normal, and if it is going to get lower, different labs have different ranges. So it is important to understand how your reagents perform, and in special cases, if the history and the clinical condition of the patient is referring, you have to take the special steps. Then comes another concept, which is actually, these are the concepts which are given by the CLIA. This is the Clinical Laboratory Improvement Amendments, as well as by the CAP accreditation bodies. So there is a calibration verification, linearity, and analytical measurement range. कुछ लग रहे हैं फौरन से बातें? ये ऐसे ही हैं जैसे आते हुए अभी नमाज की वो चल रही थी उसके ऊपर रेडियो पे, and there was a khutbah afterwards from Makkah and it was in Arabic. So after listening to certain time I said no, कुछ समझ नहीं आ रही, इसको बंद कर देना चाहिए. So if you just know the concept and then you are going to build your concepts around it. Calibration, what is a calibrator? Calibrators usually come up with your machine and they are given by the manufacturer. These are the solutions with the known values. You know that they have a known value in them. You are going to tell your instrument that if I am showing you this 10 rupees note, this is 10 rupees. It is not going to pick a 10 rupees note as a 5 rupees or as a 20 rupees, right? So this is a solution with the known value that you are showing it to your instrument, and that is performing that test in a similar fashion that you are going to do it with the patient sample. What is the linearity curve? When you do the calibrations, this is your linear relationship which you get with the dose and the response. Like if there is a dose of 1, what is the response of your instrument? Dose of 3, what is the response? And you do get a linear relationship in that. And analytical measurement range is the range of concentrations of an analyte that a method can detect without any dilution, concentration, or any other pre-treatment. That you are using different solutions or specimens as calibrators or standards, and they have the known values. One of the solution has an analyte, for example, factor 8 at a very high concentration. Another calibrator has a factor 8 at a very low concentration, and you are going to do the testing on your equipment, and then you are going to plot a graph. So multi-point calibration curves are more important for the quantitative assays. These are usually minimum is 3, but recommended is 5 to 8. Single point for semi-quantitative, where you say this is positive or this is negative. This is the type of the graph which you are going to get in the calibration curve or the linearity curve. You can see this was our AMR. We have to include the such calibrators which will cover your lower and upper AMR. And then we have a high value calibrator, mid, and the lower. And you are going to plot it. They should be in a linear fashion. If it's not linear, we can see that the certain values are falling out. It means if you are going to calibrate your instrument with these calibrators, your patient result report will be affected, right? If you are telling it that at this concentration of 0.8, your response should be at 4, although it has to be at this point, so your result will be varied. So linearity experiments, we have already talked about it. QC scheduling, when we are going to do, we have already said validation is required whenever a new instrument or equipment, a method is introduced. Calibration is done at the time every 6 monthly or maybe more frequently if your reagents, their lot has been changed altogether. There is an equipment shutdown for necessary maintenance, or there is some bias in your quality charts or your EQA results. And we have already said that the control charts with control materials, they are to be run with daily or with every batch of samples. These are some of the examples of the controls which we use in the coagulation lab. There is level 1 control, and we usually use at least 2 levels of control in our coagulation lab. One shows you the normal limit and other shows you the lower. So what should be the lower limit at this point? The new concept in the quality control is the Six Sigma approach. This approach was actually introduced in the chemical pathology, which is now being taken into the coagulation lab, into transfusion medicine, everywhere. So what is this Six Sigma methodology? Sigma represents standard deviation in mathematics, and that is based on 3 things. Total allowable error, that is the error that is allowed for your instrument or equipment to work, taking into account the biological factors. That takes into account both systematic or random errors, and the imprecision, that is coefficient of variance. Acha, ye kuch statistical terms hai. I'm not going into the detail of it, otherwise it would be like far off thing. But you have to remember mean when you are running the quality checks. There is a mean, then we have the standard deviation, which is your sample span around the mean, and then is the coefficient of variance. Variance is the measure that how much is the spread of your samples around your mean, right? So this is the dispersion terms. So just you can read a lot about the Six Sigma now, and we just know the 3 things about it, that is total allowable error, bias, and precision. And this is the DMAC approach: define, measure, analyze, improve, and control. This is the basis of this Six Sigma approach. And this theory was actually used in the industry, first of all introduced by Motorola in 1980s, and now it is also being used in the clinical labs. And there are certain values of sigma which define your performance of the lab or a single analyte you are doing. So in the end, I would like to conclude here, what are the do's and don'ts we are doing in the coagulation testing? We have to ask the question why this is happening. We have to do, unless until you don't ask the question, you are not going to do anything. And we have to look for the issues. You have to listen to your staff members and other stakeholders. Please do not blame others. If you cannot solve it, please take help. Thank you so much for the kind listening. Thank you.
Thank you, Dr. Nasish, for such an elaborate discussion on quality control. Now I'll request Major General Dr. Salim Rana. He is also the president of PSH. We all know him very well, and even when I was a junior staff and I visited Armed Force Institute of Transfusion, I came to know कि जनरल साहब जो है ना फ्री लंच एंड टी अपने बिहाफ पे सबको खिलाते हैं, और मैंने भी उस दिन वो कबाब और थिंग्स ली. So, General Salim, I'll invite you to say some concluding remarks for the session.
Thank you very much. I think we are already late in time and there's nothing much to say, and we have a wonderful presentation from Dr. Lubna. We are heading an organization on a voluntary basis, and we must give a clap to Dr. Lubna for doing this voluntarily. And this center is helping all the deserving people, and how they manage to get these factors and how they give it to them. I think it is commendable. And we are just trying through PSH to regulate this further through the public sector. And the other presentations were also very good for our panel, the foreign speaker, pre-analytic errors, which are very important. And she also spoke very well for the quality assurance. It's such a big subject, लेकिन उन्होंने उसको कूजे में बंद कर दिया, and to me, she is a very nice presenter and a good quality content of that. So this is our last session after this. And then tomorrow, mainly there are 2 sessions, primarily on blood transfusion, very important one. We have invited some very wonderful speakers all over the country. And thank you for the organizers.
We have Dr. Bushra with us. She'll answer your question answers. She's the panelist. If there are any questions from the audience, please, Dr. Bushra, I invite you to give shields to the participants. Dr. Lubna Zafar, please come and have your cue. Mr. Ahmed, on behalf of Dr. Aaron Han. Dr. Nazish Saklain. Dr. Bushra Moiz.